Hey, and welcome to TMI Tuesdays with Lauren and Di. We're your new favorite physios, and we're here to give you the down low on Down There, destigmatizing pelvic health one episode at a time. Hello, everyone, and welcome back to TMI Tuesdays with Lauren and Di. I'm Lauren.
And I'm Di.
And today we are going to chat to you about pelvic organ prolapse. So pelvic organ prolapse is a very scary word, idea, concept for a lot of people. So we want to go through the different types, risk factors, how we grade it, measure it, and maybe some myths or misconceptions as well.
Yeah. I think we can also touch on how if you are diagnosed with pelvic organ prolapse, what you can do about it and some treatment options.
Yeah, and what that kind of looks like moving forwards as well, because I think something really common is when someone's diagnosed with it, they think they have it for life now, right? So I think it'd be good to go through what that even looks like if you get a diagnosis of pelvic organ prolapse. Okay, awesome. So pelvic organ prolapse is essentially a descent of any of your pelvic organs into and sometimes out of the vaginal canal. So if you have it, or at least in the extreme cases, you definitely know, it's often associated with symptoms like heaviness, pressure, bulging. Usually people describe it as like when they're wiping, they feel this bulging. And there's 4 different types. Di, do you want to go through the different types?
Yeah, and I think that it's important. Some people think that they feel like something's falling out of their vagina. Nothing is actually falling out, but that pressure can make it feel like that. So when you think about your vaginal canal, I think of it like a toilet paper tube. So at one open end of the toilet paper tube, that's your vaginal opening. The other end of the toilet paper tube is where your cervix would be. So that's at the top. So you can have your cervix and your uterus dropping down. That's one type of prolapse. You can also think of the toilet paper tube. The front wall of the toilet paper tube can get pushed in, and that's usually where your urethra or your bladder are going to drop in. And so those organs can push on the anterior, the front wall of your vaginal canal. And then from the back, you can think of where your rectum sits behind the back wall or posterior wall of your vaginal canal or that toilet paper tube. And sometimes that can get damaged as well, and that can be pushed forward into that vaginal canal as well. So it's not that the organ necessarily is falling out or descending, but it's that those organs are pushing on the walls of your vaginal canal, and that is prolapse. Like that's what you're seeing. Those are the signs, the clinical signs.
Mm-hmm. Yeah, so the fancy terms for what you described. The bladder is usually called a cystocele. Sometimes it can be used interchangeably with an anterior vaginal wall prolapse. The uterus descending is called a uterocele. And the rectum coming into the vaginal wall is called a rectocele, and that's sometimes called a posterior vaginal wall prolapse. And then there's also an enterocele, which is when your intestines come down, but that's less common, and I've never actually seen that in practice myself. Have you?
I've never seen that in practice either. No.
Yeah. And like you said, there's no hole, especially in the anterior wall and the posterior wall. It's not like there's a hole, that the wall has thinned and weakened and it's pressing into it. Yeah.
And you can also have more than one type of prolapse at the same time. So you may have a cystocele and a rectocele. So both front and back walls can be pushing in at the same time. So it's important to note that there's lots of different options and varieties out there.
Yeah. And another one also actually is a urethrocoele. So you can have just your urethra, which is where your urine comes out. It's like a little tube. That can be prolapsing as well. Quite often it's coming along with a cystocele, so the bladder prolapse, but I have seen it just the urethra on its own as well.
Yeah. Exactly.
Yeah. So how we stage it or grade it. So there are 4 grades or stages, grade 1 to grade 4. And so this can be done just digitally with fingers, but you can also use the pop cue, which is basically like these popsicle sticks. And you take a bunch of different measurements across the vaginal opening and then up into the vaginal canal as well. So grade 1 is essentially one of the organs or multiple of the organs have dropped down 25% into the vaginal canal. So if you think of like Di gave that example of the toilet paper tube, so it's dropped down 25%. Grade 2 is 50%. Grade 3 is it's at the vaginal opening, so you can see it right at the opening. And grade 4 is it's all the way. So again, that's usually the grade 3 and the grade 4s are the ones that are most distressing and people feel like something is falling out.
I just pulled them up the staging of the pop cue system. So that's where they're measuring with those little popsicle sticks. So they have 4 stages as well. They start at stage 0, which is no prolapse. Stage 1 is under 1 centimeter above the hymen. Stage 2 is equal to or above 1 centimeter above or below the hymen. So again, you've got a bit more of that. And then stage 3 is below 1 centimeter beyond the hymen, but not fully prolapsed. And then stage 4 is a complete eversion. So outside of the vaginal, think of like outside of your vagina, it's totally dropped down. So interestingly, I looked up a couple other interesting statistics, and a study in 2008 and 2016 found that about 40 to 50% of women will have some degree of prolapse visible on exam across their lifetime, but only 3 to 6% report symptoms, which is great because I think that a lot of people are really afraid of having being told they have prolapse, and being told, especially if it's a grade 1 or a grade 2, they're really worried that that's going to lead to symptoms and really change their lifestyle or really impact their life in a negative way. And it's really nice to know that although a lot of people may clinically have signs of prolapse, that they don't have any symptoms that are going to negatively affect their life.
Yeah, I'd be curious. That's an interesting statistic. And I'd actually be curious to know specifically what percentage have that within the first 6 weeks postpartum, because that's something I hear a lot from my clients. And especially after a vaginal delivery, I get a phone call or an email. Someone's really, really in distress. And I try to educate them that there's things that they can do, but the difference between week 1 and week 6 postpartum is just huge in terms of some of those symptoms of heaviness, pressure. And just because you're having those feelings and those symptoms now does not mean that now you have a prolapse forever. Like the majority who get on it right away and start seeing pelvic floor physio, early on and, do the right things and don't panic. Usually even by 6 weeks, they're feeling way better and beyond.
I think this is why, I know this is one of the reasons that I often tell people I'm happy to see you before, and even just for a video call for people postpartum before the 6-week mark, because the last thing we want is people to be feeling these symptoms, knowing a little bit about prolapse, and then catastrophizing, which is only going to make their symptoms worse. Or not being active because they're scared they're going to injure themselves and just things like avoiding walking or the stairs because they're worried that's going to make things worse. I actually find that, yes, the first 6 weeks it often will show up, but I find that around 8 weeks is often a time that people notice it as well. And I think that's because a lot of times there's a lot of swelling in the vaginal canal because you've just gone through labor and delivery, and depending on what that looked like, you can have varying ranges of swelling in there. And once that swelling actually goes down around the 6-week mark, then they can start to feel some prolapse as well or that pressure, that heaviness. And that's just because they're getting used to kind of a new normal where the space that was their vaginal canal, the space that maybe is swollen, is kind of being taken up space by the swelling. And once that swelling goes down, it feels like there's more room and organs are kind of feeling like they need to get readjusted into their new living location. And so I feel that around the 8-week mark, people also often feel those symptoms, and oftentimes those will go away within a few weeks after that, once their body kind of reacclimatizes to what the new normal is. The other thing I liked, and we'll talk about a little bit more about this when we talk more about kind of why some of the contributing factors to prolapse. But I find that people, when they stop breastfeeding, also their symptoms often improve as well. And that's a lot to do with the hormonal changes that they go through when they stop breastfeeding. I think it's really important if you are experiencing prolapse type symptoms, so that heaviness, feels like something's maybe falling out postpartum, to see a professional and to like not panic, because a lot can change within that first year or two.
Yeah, it's a good point you brought up around the 8-week mark too. Sometimes I can also see, people have gotten their clearance to resume physical activity at 6 weeks, and sometimes they kind of jump into things that they were doing before without sort of that gradual progression, and that can sometimes contribute to those symptoms flaring up around maybe 8 to 10 weeks because they've done this big spike in their activity level, and their pelvic floor maybe hasn't had that time to retrain and adapt to that level of physical activity too. So that
Yeah,
can be another reason why. And it's not
exactly.
that you shouldn't then be active. It's just sometimes figuring out the right amount and the right progression for you. It's like resuming any physical activity after any injury, right? The symptoms are going to flare up if you kind of boom or bust, right? And jump into too much too soon. So it's the same way postpartum.
Yeah, something else that I get asked a lot about prolapse and around people who are having babies and of that childbearing age is, if I have prolapse after my first, and say I had symptoms for the first year or so and then they started to get better, will my symptoms get worse with my next pregnancy? I don't know what you find, but I find that no, a lot of times people actually do a lot better because they have tools in their toolkit already to manage that pressure and to know what to expect, to not panic, and then they often do better and have less symptoms, I find, with future pregnancies.
Especially if they've done pelvic floor physio postpartum. They're usually way more connected to their pelvic floor and, like you mentioned, pressure, which we'll talk a little bit more about. And if they're kind of checking in and keeping up with their pelvic floor physio during pregnancy as well, I also find they tend to do way better as well. So a
Yeah.
little bit of awareness and understanding of the system and how to use it better can go a long way in supporting you in future pregnancies. So definitely pressure management is a big one, and a big one that we as physios focus on. So I guess there are what we would call modifiable risk factors and then non-modifiable risk factors. So maybe we'll start with some of the modifiable ones. So pressure management is a big one. So people that hold their breath quite a bit when they do things. What breath holding does is it pushes down, it puts pressure down on the pelvic floor, and then the pelvic floor is opening and expanding rather than squeezing and lifting. So this can be somebody who does heavy weightlifting if they're not connected to their pelvic floor, and how to engage and manage that pressure well, even before pregnancy. Usually I find those that struggle in pregnancy or postpartum, they likely had this dysfunction before, but weren't symptomatic. And then you throw pregnancy on top of that, which adds more pressure. And that can kind of aggravate things and set you up for more issues postpartum. And it's not that you can't lift heavy and shouldn't lift heavy in pregnancy. It's just learning to connect better and learn how to manage that pressure through pregnancy. So that one, and then either weakness in the pelvic floor and or too much tension in the pelvic floor can also be contributing factors. Lack of the knack reflex, we call it. So the pelvic floor should automatically and reflexively squeeze and lift just before coughing, sneezing, laughing, jumping, lifting. And for a large percentage of the population, that happens automatically before pregnancy. But for some people, it's not even before pregnancy. And so what happens when you're coughing, sneezing, laughing, instead of the pelvic floor holding everything up, it's actually everything's getting pushed down. And so again, if you're lacking that knack reflex going into your pregnancy, and now baby's growing and there's more pressure down, it's becoming even harder to support those organs. And then same thing after a vaginal delivery. I'll let you take on some more here.
Yeah, so if someone has a chronic cough, that can be a contributing factor. And then also even things like if you're doing high impact sports like running or jumping that are consistently, again, putting that downward pressure on your pelvic floor, that is a bit of a risk factor. And we're not saying that you shouldn't do those things. It's just about managing the pressure properly and making sure that you have coordination between the muscles to lift up as much as possible instead of pushing down. And then we can look at some of the more non-modifiable risk factors. So,
one more modifiable one is constipation. That's a
oh,
big
yes,
one
yeah.
for people too, is chronic constipation or even just power pooping. So maybe you're not even constipated, but you
And
just have
power
developed
peeing.
power peeing. Yeah, power toileting. So maybe you're not even constipated, but you've just developed this habit of get in, get out, right? I don't have time for this. And so what you're doing is you're bearing down, you're pushing everything out. What should be happening when you're toileting, both urinating and bowel movements, is your pelvic floor should just relax. It shouldn't be forced or pushed down. And so if you're constantly straining, bearing down, power pooping, or if you have constipation, that's a huge risk factor outside of pregnancy. But you add constipation onto pregnancy, and that's just not ideal for your pelvic floor. So that's why we often, as pelvic floor physios, are asking right away about your poop habits, because we want to make sure that we're addressing that. We did a whole episode on proper pooping, so feel free to go check that one out for tips and tricks. But super important to make sure that you're having healthy, happy poops and you're not having these behavioral habits of bearing down and forcing, because that is a recipe for disaster. I'd say that's actually probably one of the biggest risk factors.
Yeah, I agree. So some things that are more non-modifiable. So things like menopause. So when your estrogen level drops, you're going to lose some of estrogen plays a really huge role in your vaginal tissues and keeping everything plump and that space again nice and filled up. And so when you go through menopause, you have a huge drop in your estrogen levels. And so if you're not on a hormone replacement therapy, then that estrogen is lower, your vaginal walls become a little bit thinner, and you might notice. So you may have had prolapse before, but you may notice the symptoms more, or it may actually progress during menopause. So a lot of people in their 40s to 60s, that's when they start to notice some symptoms as well, and that's really common. You're also going to look at genetics and connective tissue. So another risk factor is genetics and family history. So if you, your grandmother, your sisters had or have experienced prolapse, they see that there's a more likelihood that you may experience that as well. Some of that is connective tissue pliability. So if you're a more hypermobile person, again, your joints just naturally have more laxity, or your connective tissue has a bit more stretch in it than the average person. And there's a whole bunch of tests that you can do to find out if you are higher on that hypermobility spectrum. What you want is for your vaginal canal and that pelvic floor to be lifted up by fascia and ligaments and connective tissue pulling upwards through your abdominal cavity. And if you don't have that, then you don't have as much support, and that can also be a risk factor for prolapse. One of them that I don't really love, but it is a risk factor if you're looking at it, is obesity and BMI. And I don't like BMI for so many reasons, because it's faulty in so many ways, but there is a risk factor with a higher weight, and that's just, again, the weight that's pushing down onto the pelvic floor. You can think of that like in pregnancy. It's why a lot of people feel it more in pregnancy if they do start to experience prolapse type symptoms. Sometimes pregnancy is kind of the precursor for a lot of people, and it's because they've got this increased load on their abdominal cavity, basically. Another one is increased with age, so especially over age 50. And again, you can link that pretty closely with menopause. That's when your estrogen levels are going to change and decrease. And then you can also look at how many vaginal births you've had and if there's been instrument usage. So as a pelvic floor physio, personally, I very much advise patients to not, if at all possible, not to have your provider use forceps during a vaginal delivery, because we do see a very strong increase of higher stage prolapse later on with forceps delivery. If people are asking me about that, I almost always say I would personally opt for a C-section over having someone use forceps on me, because I don't want to increase my risk of prolapse postpartum or later. And I've talked to a lot of OBs about it, and most of the OBs are in the same boat. A lot of them won't use forceps anymore, and they'll just opt for a C-section. But it is something that I do talk to patients about, because it is still used sometimes.
Yeah. Yeah, I have that conversation as well. Another one is length of pushing phase. Anything over 2.5 hours is also a risk factor for prolapse.
Yeah, exactly.
Yeah.
So those are the risk
Actually,
factors.
well,
Go for it.
another one we can talk about, which I think we need to have a discussion about, is, and this kind of goes along with hypermobility in the connective tissue that we talked about, but the genital hiatus width or measurement. So this is something that I'm seeing a lot more in practice in pelvic floor physios. Seeing a lot more in the literature as well, is the larger your genital hiatus, which is basically the space between
the external urethral meatus and the posterior midline hymen, measured during a Valsalva.
This part.
Yes.
Okay. So genital hiatus is essentially the space, your vaginal opening, essentially. So the space here. And so that is often measured and is starting to be measured more and more by pelvic floor physios during a Valsalva maneuver. So when bearing down. And actually, to go back to how pelvic organ prolapse is assessed, I don't think we mentioned that, but it's also when you're bearing down. So you're usually in a lithotomy position or on your back, and you're bearing down or pushing, which essentially moves the organs down and opens the pelvic floor. So that's the position and how we assess pelvic organ prolapse, the grade of it, and then also the genital hiatus measurement. Now, this is something that a lot of physios are educating their clients on and patients on, and I have mixed feelings about it because it's a non-modifiable risk factor. So you cannot change the size of your genital hiatus. And even though it is linked with pelvic organ prolapse, and I think it's important that clients and patients are educated on what's going on in their body to be able to make informed decisions, I think pelvic floor physios have to be very, very, very careful about how they're delivering this information and just how they're using it. Because it's, especially around birth and prolapse, we have the power as pelvic floor physios to really cause more harm than good, to cause fear, to really over medicalize birth, and to just, it's something called the nocebo, which is the opposite of placebo, right? Create a negative effect on our clients. And so I have a lot of concerns about how readily this is being shared and passed around. And I'm not saying that we shouldn't talk about it. I think patients are entitled to have all of the information, but I think I'm seeing it tossed out lightly without the implications and truly getting a sense of how their client or their patient is taking in this information. So what are your thoughts on it, Di?
Yeah, it's not something that I clinically do. I don't test this. Do you test this?
I haven't been. I actually have a meeting set up with the two other pelvic floor physios on my team to talk about this in a couple weeks, because we all want to make sure we're on the same page when we're working with clients, because we're on the same team and we want to practice similarly. So we have actually a whole meeting dedicated to this topic, to review the literature, to review what they've heard, what they're seeing in practice, and just what our thoughts are on it moving forwards, because I do feel so strongly about delicate of a topic this is. Yeah.
Yes,
So
I
no,
agree.
not
So
actively.
I don't actively either. I've had friends actually go to really good, like very amazing pelvic floor physios, but they are naturally more of a highly anxious person. They got told that they were at a higher risk factor, and I don't necessarily think it helped them prepare for birth and labor and delivery. I think it instilled maybe a bit more fear. And I think that there needs to be a lot of communication under what those results mean and what you can do about them. So basically, I personally, being pregnant, have gone and seen my pelvic floor physio, who's wonderful. She was great in that she asked if we had a conversation about if we would do this testing or not. I asked her to do the testing because I did want to know, and it's something that she was going to be able to monitor throughout my pregnancy and see if that changed at all throughout my pregnancy. I do live more on the high end of the hypermobility spectrum, and so I was really curious to see, okay, at 13 weeks and at 28 weeks, is there a difference, or have things changed, or are they pretty stable? It wouldn't move me to decide to get a C-section versus have a vaginal birth. But for me, it was just a lot more just another piece of information that I could use when I'm making those decisions. So I think that it's something that can be helpful to people if they want to know and are able to understand that this is a risk factor for prolapse, but it there's not a direct correlation. So just because you have a higher number doesn't mean that you are absolutely going to get prolapse after having a vaginal birth.
Yeah, that's what I wanted to touch on too. Going through all of the risk factors that we went through, it's important that it's presented as this is just one risk factor, right? And it's so hard to academically study these things because there's so many things that contribute. And so I think if we put so much emphasis on these GH measurements, then we're not giving our clients this sense of control over their experience. And they'll then go into feeling like helpless in birth. Even if we can tell them, oh, well, you do all these pelvic floor exercises and it'll lower your risk factor. No, I think it's really important that it's emphasized that this is only one piece of a very large pie and puzzle. So I don't think educating on doing the exercises actually helps reduce the fear. I really believe that educating on what all of the risk factors are and that this is only one small piece of that. Some people might argue that's not a small piece, but I think that is going to be what helps to reassure people more.
Exactly. It's taking a look at all of the risk factors together. If you only have one risk factor versus you have lots of risk factors, how does that play into your decision making? So the other thing that I think is really important is that people can have prolapse. Again, it might show up a bit later in life, but it could show up at any time without having children or with having a C-section. So just because you don't have a vaginal birth doesn't necessarily mean that you're not going to experience prolapse in your lifetime.
Yeah. Less likely, but still definitely
Most likely.
possible. Yeah.
Yeah.
So should we go through and talk about management?
Yes,
Because this is
absolutely.
one, I think, coming from more athletic backgrounds, both of us, not to toot our own horns, but I think we're both very good at managing this in terms of exercise progression and really reducing the fear around exercise. Because I know for a while, it's like if you just focus on the pelvic floor and this avoidance approach of don't heavy lift, don't exercise, don't heavy lift, avoid walking, limit your time on your feet. Like that is so not the way that we want to do things. So do you want to take kind of the first 6 to 12 weeks and I can kind of go from there?
Yeah. So if we're thinking about postpartum, I think of when you're thinking of recovery postpartum after having a baby, usually most people, if they're exercising pre-pregnancy, their exercises will change and they may be more focused on body weight exercise, working on connecting to their pelvic floor and their core muscles. And that kind of changes into the third trimester. I find that that's when people change. And it's about 6 weeks that people end up changing that and starting to focus on labor and delivery. And I find that it takes about the same amount of time postpartum for people to, again, you want to start with what you finished with. So you want to start with working on breathing, make sure that you're getting that deep diaphragmatic breath, breathing all the way down into your pelvis. And then as you ideally, an ideal world, you breathe in, your diaphragm drops, your pelvic floor lengthens. So you're getting that natural lengthening. As you breathe out, both the pelvic floor and the diaphragm are going to lift together. So you're starting to get that pressure management system just by doing some breathing work. It also helps you relax any tight muscles. So what we talked about earlier is that having a pelvic floor that's holding too much tension can also contribute to prolapse symptoms. So making sure that you're breathing deep into your pelvic floor, getting that movement going really early. Then you can start doing some deep core activation. So Kegels, transverse abdominis activity, and then moving from there into things like walking are great. And then moving into body weight exercises. So really working on getting that pelvic floor and that exhale, ideally just before the start of the hardest part of your movement. So playing around with that, everyone's going to be a little bit different. Say for squats, some people find that they're better to start that at the top of their squat as they go down and come back up. Other people find that they are better breathing in on the way down in their squat and then breathing out, so that exhale to kind of lift the pelvic floor naturally and help engage the core and think of the pressure coming upwards as they come up from their squat. So really working on body weight exercises, walking, light cardio. So things like biking. Some people find elliptical is okay at that point. Again, everyone's a little bit different, but nothing that's going to put too much downward pressure on the pelvic floor. So we don't recommend a lot of jumping, running, anything that's gonna kind of put that downward pressure on, or lifting too heavy. So you want to start off light and build yourself back up. And then I also find that doing some of these exercises with a pillow under your hips, or things like bridges where you're letting gravity help pull everything back kind of into your abdominal cavity, can help as well. So if you're doing those deep breathing exercises and you are feeling some prolapse type symptoms, doing some deep breathing or some core exercises or some Kegels with your laying on your back with pillows under your hips can be super helpful as well.
Yeah, just in terms of symptom management for the early stages, things like legs up the wall can be really nice because gravity is pulling everything down with some of that breath work. Yeah, bridging with your legs up on a bed or a couch or a chair can be really nice too. So yeah, I the main three things I look at in those first kind of 6 to 12 weeks is breath and coordinating breath with the pelvic floor, like you were talking about. So inhale, relax, exhale, contract, and then starting with that at rest and then adding the movement to it. And then the neck reflex is a big one. So making sure that pelvic floor is reflexively engaging before pressure. So coughing, sneezing, laughing, lifting. And as we start to get into movement, is that pelvic floor reflexively engaging when you need strength? Because that's a big risk factor for increased symptoms when you're starting to exercise, is if you're doing things like, say, lifting, and your pelvic floor is opening during the most exertive part of the movement, then that's going to exacerbate those symptoms, especially if you're lifting like a baby or a toddler repeatedly throughout the day. So it's not the exercise that's causing the problem, it's sometimes what is happening internally that's causing that problem. So a lot
So
of
it's about getting the
mind-muscle
coordination.
connecting.
Yes, I was
Yeah,
going to say it's about the
coordination.
coordination. So that mind muscle connection. And I don't know if you get asked, but I often get asked about abdominal binders or waist trainers postpartum, and I am adamantly against them. A belly band that works. So Bellies Inc. is a Fraser Valley, Vancouver local company. They make a really great one because it pulls upwards, and especially after something like a C-section, it can be really helpful. But if you are looking at some sort of belly support, you want to make sure that it's tighter on the bottom and looser on the top, so it's helping pull everything up. You don't want anything that is going to be tighter around the waist or the ribs that's going to be putting downward pressure on your pelvic floor. So no to abdominal binders and waist trainers specifically, but yes to a belly band support that is specifically designed to lift up postpartum. Some people find that a compression garment like the V-sling can be an option as well. Most people find they don't need this, but if someone does feel like they've got a lot of that downward pressure when they are standing, then that is an option for people, especially in those first couple weeks, just to give them a little bit extra support as well.
Yeah. Yeah. So exercise progression postpartum, I describe it kind of like a ladder. So again, we're starting with the basics in those first to 6 weeks. So can you contract and relax your core and your pelvic floor in isolation? Then can you coordinate it with movement? So again, we talked about the coordination, getting that engagement on before the strength part of the exercise. Then can you start to use it with load? So now that we've got some movement going, can we start to add load? So some light weights. So even just basic upper body exercises like bicep curls, shoulder press, squats, lunges with weight, and starting to pay attention to, again, is my pelvic floor lifting and supporting me during the exertion portion of the exercise? And so it's a really great time to think about your pelvic floor and to train it and to coordinate it with movement to start to get some of that core and weight work going. And then once you have good control and your symptoms are well managed at that level of the ladder, can we then start to add impact? So we want to make sure that as we're going up the ladder that we're not progressing to the next stage until our symptoms have kind of plateaued or settled. And by symptoms, I mean that heaviness, that pressure, that bulging, feeling of falling out. Usually as we go up to the next stage of the ladder, you are going to likely get a little bit more symptomatic. That's normal. And I always try to educate on that. And we don't want to push beyond that level of the ladder until the tissues have adapted, pelvic floor has adapted, and as those symptoms have come down, then we move up to the next stage. So again, we're usually not introducing any kind of high impact exercise until at least 12 weeks, usually later with prolapse, because it usually takes a little bit longer, depending on the person, to get through those levels of the level.
Exactly. And then two of the other things that can also be helpful is either vaginal estrogen or vaginal hyaluronic acid. So making sure that you are able to plump up those tissues. So while you're breastfeeding, you also have a decrease in estrogen, just like in menopause. So those tissues are a little bit thinner. Your symptoms are likely going to be more apparent. And so talking to your primary care provider, that's not something that as physios we can prescribe, but talking to your primary care provider about options like a hyaluronic acid that you put vaginally to help plump those tissues up. Or for some people, that's a vaginal estrogen, and that changes person to person, is a good option. And what I find is also pessary use. So I don't personally fit pessaries at my clinic, but there are clinics in Vancouver and the Lower Mainland that I refer to often for this. Really good providers that do this. And a pessary is kind of like an ankle brace, so for your pelvic floor. So if you sprain your ankle and you're wanting to go back to play soccer and you need some extra support, that ankle brace that you wear can give you that extra support while you're still rehabbing. And pessaries are the same. Pessaries aren't necessarily a short-term or long-term solution. Everyone's a little bit different. Some people find that they wear them for a short period of time. Other people find that they wear them for, long period of time. Some people find that pessaries are something that they're going to wear all day, and other people want to only be wearing them or have that extra support when they're doing activities. And so a pessary can be a really useful tool, and that's something that we can help people figure out if that's an option for them. A lot of people seem very against them when I bring it up in practice, and patients are. And I find that so interesting because if it was something like a sprained ankle, people wouldn't think twice about it. And I think that there needs to be more awareness about the fact that this doesn't mean that you're failing. It's just a tool that you can use to help you feel better and maybe help you get to that next step in the ladder if you're having trouble reaching that next step.
Yeah. Yeah, I find they're really great for people who are very distressed by the symptoms because we can get stuck into this loop where we feel these symptoms and it makes complete sense why people are distressed. Like you feel like your vagina is falling out of you. Like obviously you're going to be distressed by that, but somebody who's a little bit more anxious or maybe more prone to catastrophizing, or maybe they're just, struggling a little bit more with their mental health postpartum, their baby's really fussy, not sleeping well, or, there's some history of mental health there, then those symptoms can it's just another thing that's just too much for your system, for your mental well-being. And, the more anxious and distressed we become about the symptoms, actually the worse the symptoms become. Not only the physical ramifications, because when we're stressed, our breath pattern changes. We tend to hold our breath. We tend to overgrip, over tense. We want to try to hold everything in. And we know that that can make things worse. It actually increases the pressure over time. So not only the physical ramifications from stress and anxiety, but also it heightens our awareness of the symptoms. So our nervous system is going to be more sensitive when we're more upregulated, more anxious, more stressed. And so that heaviness, that pressure, it's a sensation from your nervous system too. And some people can get it even without a prolapse present, which indicates that just because we have that sensation or the level of the sensation does not always correlate to the grade of the prolapse too, because the nervous system is a big contributor to those feelings that we're having in the pelvic floor. And so a pessary can sometimes really help support people to calm those symptoms down, to calm that level of distress and that anxiety, so then they can go further, like you said, on that ladder in their rehab.
Yeah. I was going to just say that, yes, exactly what you said. Some people are more, I find also with people who are highly athletic or more body aware, or generally hypersensitive. So if someone is hypersensitive, things like socks bother them, like they're more sensitive in their skin and within their body, they may be feeling the symptoms more than somebody else who they might both have a level 2 or stage 2 prolapse, but one person might feel it completely different from the other person. So it's really important that we are looking and talking to you about your symptoms as a patient, not just looking at a grading scale.
Yeah, and I think this goes back to the conversation around how we educate on risk factors for prolapse, because we know that it can be such a distressing thing. For somebody who's more hypersensitive, yeah, we just need to be conscious of that education and how that might sensitize their system as well. So, yes, be careful of your words. We hold so much power as pelvic floor physios.
If someone is having a lot of problems and they've gone through pelvic floor physio and we've been working with them, or they have a very high stage prolapse, so especially that stage 4, often pelvic floor physio is not enough. And so sometimes those people need to see a gynecologist, and surgery is an option. So there are things that you can do that are a bit more invasive. Interestingly, the risk of reprolapse post surgery is actually quite high. I can't remember what the actual statistic is, but it's actually quite high. But the incidence of symptoms increasing actually isn't very high. So it is really interesting, but surgery is an option for some people, and that is always out there as well.
Yeah, and we're biased as pelvic floor physios, but the evidence also shows that you should always do pelvic floor physio before surgery, and I feel that that risk of prolapse is high because if you sling up and surgically support that organ, but you haven't retrained those contributing factors as to why it's getting, pushed down to begin with, at least those modifiable ones. Like, say you're still constipated, say you still have a chronic cough, say your NAC reflex, that automatic recoil, or your pressure management has not been retrained, then you still have all of that downward pressure. And now you've got this surgically lifted thing. And if you haven't addressed the underlying causes, then it's obviously not going to stay over time.
Exactly. So pelvic floor physio, super important pre and post sling lift, basically, or surgery for prolapse. And so I think it's important what Lauren said. Yes, we need to look at all of those modifiable risk factors, but also it's just like anything. Before someone has knee surgery, we always want them to be going to their physio beforehand. If you're able to get yourself in a place where you can understand the coordination and feeling your pelvic floor contract and relax properly, and get your strength up as much as you can before surgery, you're going to do better post-operatively. The results are just really strong for that in any situation. So any pre-surgical thing, we always want to do pelvic floor or regular physio beforehand. So that's something to think of for if you are looking at getting surgery as well. And you want to I'd give it like 3 to 6 months of solid prehab, like pre-surgical rehab for most people. I think it's not just a 1 or 2 week thing. It takes 3 to 6 months of consistent work to really see those results post-operatively.
Yeah. Well, the wait times are usually pretty long for surgery anyways, so there you go. Use that time to do your rehab. Yeah, this was a long one, but I think it's really important that we took the time to go through all of these things because, again, there's just so much fear around this topic, and I'm really passionate that you should be working with somebody who's really comfortable and confident with prolapse as well, because not every pelvic floor physio is. And someone who can progress you and you're not just lying down and doing Kegels, or even just sitting and standing and doing Kegels, because you've got to be able to make it functional, especially if you're active and want to be active again. You've got to get that progression up that ladder over time. That's usually a big missing piece for a lot of people. Yeah. So thanks for tuning in to another episode of TMI Tuesdays and for chatting and listening to us chat about pelvic organ prolapse. So we went through the different kinds, we went through the risk factors, both modifiable and non-modifiable. We talked about how to recover, rehab, and progress. And we chatted about some of the myths and misconceptions about it and some of your other options other than pelvic floor physio. So if you have any questions, comments, you want to share any pelvic organ prolapse stories yourself, feel free to send us a DM or an email. And we're happy to chat further or answer any more questions that you might have. So have a great rest of your week, and we hope you tune in again next week to another episode of TMI Tuesdays. And that's it for us. Keep it tight.
But not too tight.
And we'll see you next Tuesday. Bye. Thanks for tuning in to TMI Tuesdays with Lauren and Di. We hope you laughed, learned, and didn't clench too hard. Please subscribe and share with your gals or guys who may need some pelvic floor love. We can't wait to hang with you again next Tuesday.